Good afternoon and welcome everyone. My name is Mike Meldrum, President and CEO of the Calgary Health Trust. Thank you for taking time to join us today as we launch our new speaker series, Healthcare in Today's Reality. We started this series because we wanted to find a way to connect with you, our donors, with top doctors in Calgary to discuss pertinent healthcare topics that are relevant to us and the way we live. Topics that impact our community and that showcase how donors are really making a difference and helping to improve our health. With the recent developments of COVID-19, we knew that the time was now to start this conversation. We are very excited to have two of Calgary's top doctors here joining us today as we dive into the COVID-19 and specifically how it's impacting Calgary. Next slide, please. Before we get started, I wanted to take a moment to acknowledge the impact that each and every one of you is making on our healthcare system. Calgary Health Trust has been around for a long time, over almost 25 years, and we work with many of you to make investments to improve our health system, to have the great infrastructure that we have today. The reality is without the community's generosity, we would not have the foundations of the strong and agile system that we have today and that has been able to respond so well to the global pandemic. This slide actually highlights the extracorporeal life support simulator that was funded a while ago from a generous donor. The ECLS is a procedure that allows physicians to be able to take over when mechanical ventilation no longer works. And this has become this simulator has allowed for additional training and has been very meaningful, the training, as we look at the pandemic. And so a great example of how donor dollars have actually previously have helped develop the training and systems that support us in this particularly challenging time. If you can advance to the next slide. So we are also grateful for those that continue to support our Clean Hands, Giving Hearts campaign, which is our COVID-19 response fund, used to assist the greatest needs with respect to our pandemic response. Our focus has been for the support of frontline healthcare workers, enhancing the public health and safety of vulnerable populations, and scaling our mental health support to meet the needs of our community. For example, if you could advance this to the next slide. Thanks to donors, the Calgary Health Trust was able to be part of a Text for Hope campaign, which is a free service that sends a daily text of support during these challenging times to anyone who signs up. The Clean Hands, Giving Hearts campaign has also made it possible for Calgary Health Trust to think about how we can create better integration and agility to effectively respond to the evolving needs into the future. We're proud to currently be supporting 2 clinical trials. $150,000 will be put towards a province-wide outpatient initiative called Alberta Hope COVID-19, which involves researchers at both the U of C and the U of A. This trial officially launched on Monday of this week. A second trial is a Canada-wide inpatient trial that allows for rapid research to take place on the effectiveness of a number of treatments for COVID-19. To date, we've committed $100,000 supporting this trial, thanks to donors like you. These are just a few of the examples of how your support is making a difference. I have a few housekeeping items I'd now like to take care of, and then we can get started. First, I'd like everyone to meet Valerie Ball. Valerie will be your moderator, our moderator, and will be able to help with any technical questions you might have. Please use the chat function. I believe it's at the bottom of your screen to ask for her assistance. Also, we'll be doing a Q&A or a question and answer session at the end of this talk. And if you have any questions, use the Q&A feature at the bottom of your screen. Valerie will help us get to as many questions as possible at the end of the presentation. Finally, we'll be recording this session and on Friday, we'll be sending out an email or emailing a link to the presentation if you'd like to watch it again or share it with some friends. Without further ado, I'd like to introduce to you our speakers today. John Gill is a doctor, is a Calgary infectious disease specialist with Alberta Health Services. He obtained his medical degree from the University of Birmingham in the United Kingdom, after which he received additional training at the University of Manitoba in internal medicine and at the University of Alberta in infectious disease. Since 1989, he has been the medical director of the Southern Alberta HIV Clinic. His interests are vast when it comes to the area of infectious diseases, and that can be seen in the over 400 peer-reviewed publications he has. Next, you'll hear from Dr. Sid Viner, who is the Calgary's own medical director. Dr. Viner has over 25 years of clinical practice and medical leadership. As a leader, he has always had a strong focus on patients and constantly looks for ways to improve quality of care and patient safety. This focus really does help to transform healthcare in Calgary. Dr. Viner has held a variety of roles, including Director of Intensive Care, and has a specialty in respiratory and critical care medicine, and is in his current role as Zone Medical Director. I have the opportunity to work very closely with Dr. Viner and can tell it is a great privilege to have both of these gentlemen, can tell you that it's a great privilege to have both of these gentlemen joining us today. Now I'll pass it over to Dr. John Gill to begin our talk.
Thank you very much for inviting me. I'm unlucky enough to experiencing 2 pandemics in my career. My first one, of course, with HIV/AIDS starting in '85, and now towards the end of my career, I'm involved in another one. This second pandemic is really difficult to keep up with, and I'm sure that many of you are overwhelmed. Every channel I go to, every newspaper I read, every blog I read is full of mixed messaging. The mainstream and social media are in overdrive at the moment regarding anything for their readership on COVID news. Part of this are what they describe as papers, which are picked up by the media and immediately hit the local rags before they've received anything, any peer review. And this is because in the last few years, I can write a paper saying apple juice cures COVID, put it on a website saying it's under review, and the media will pick it up. So there is no quality assurance on some of the science out there, which makes it very messy for you and I to understand it. Some of the science may be correct, but may jump to premature conclusions. It may be incorrect, or it may be incomprehensible. And when you look at it, think this will never pass the usual peer review process. Even when you go to top peer review quality journals, some of the articles are a bit premature, they're overinterpreted, or they haven't received enough time for good peer review and thought to give a correct interpretation or a really good interpretation. So it is very noisy out there. And why is this? Well, there is immense pressure for the authors, reviewers, and the journals to be fast and first and get the papers out there for a very hungry public. So the first message is be very careful and prudent when you're understanding any of the messaging in the media. Next slide, please. So to give you a little bit of the basic viral facts, the virus is called SARS-CoV-2, and that causes COVID-19 infection. So virus has got a separate name. The infection is COVID-19. It's an RNA virus. It belongs to the coronavirus family. And the next point, it's a respiratory virus. This is something you inhale or you get into your respiratory tract. It is not mosquito-borne, which would be arbovirus. It's not a blood-borne virus like hepatitis. It's not an enterovirus like noro. It's something we basically gets into our respiratory tract. The whole coronavirus family is well known to us because many of the coughs and colds we've had in the past are likely the benign members of the corona family. Recently, though, about 20 years ago, the virus SARS virus, coronavirus, and MERS virus appeared that were far more sinister and serious than their benign coronavirus cousins. This virus loves a receptor that's found in our respiratory tract, often in the lower respiratory tract, called the ACE2 receptor. So it's the way it attaches to the human and gets into our cells is through the ACE2 receptor that's in the respiratory tract. It is very high affinity for that receptor, much higher than the SARS virus. So it's sticky. It loves our respiratory tract where it causes us grief. Next slide, please. The next question, where did it come from? Well, the science at the moment is pretty compelling. It probably comes from bats, and bats seem to behave harmoniously with many coronaviruses. Then it may have hopped to an intermediary host, and some people think that the Asian pangolin was the intermediate host. Some people believe it just hopped straight to humans by people working with bats or even feeding them, eating them, whatever. But in humans, this virus is not good for us. We've been able to study the virus fairly well, and the good news is some of the antigens that we might use for vaccines aren't changing much. And it is, however, changing a little bit, which is allowing us to track how the virus is changing over time. And we can find where viruses likely originate. Some of our North American strains came via Europe, some came via China, and they got slightly different characteristics. Now, the message from all of this is it's a new virus. No one is immune. Past exposure to coronaviruses are not protective. Next slide, please. How do we diagnose this COVID-19 infection? Well, the best way is a nasopharyngeal swab, which is a wiggly swab that is pushed far down the nose, and it gives us a molecular test. It's not viral culture. It tells us viral genes are there. Now, unfortunately, we're short on swabs, and that's not easy to do. But another test is now being used, which is a deep oral swab, which is maybe as good as the NP swab. Now, with any test, the test is only good as the sampling. If you take it really early in an infection, you might miss the virus. If you don't take it from the right swab or you don't handle it, that might be an error as well. So testing does have some false negatives. It needs to be done well and properly. Unfortunately, I think in Calgary, we're doing pretty well on this. We don't test asymptomatic patients. We do people who are symptomatic, and that means there's a little bit of a hole in our knowledge at the moment that might be filled in the near future. The next key that is important to disentangle all the noise out there, we can find viral sequences. This doesn't mean that there's necessarily an active infectious virus there. It could be the viral genes from dead virus. Doesn't mean it's necessarily infectious. It means it's interesting, maybe worrying, but it doesn't necessarily mean infectious virus. The next noise we're hearing is about antibody testing. Well, an antibody test that is specific for COVID-19 would be really helpful because it would tell us if we'd had it and had a low-level infection. It would tell us if we are likely immune, and it would tell us how many of our population are at risk for this. That test is not yet available. Reading CNN this morning, some of the tests that have been approved are giving false positives and false negatives. Before we introduce an antibody serology test, we really need to know it works. This is not one to rush and get wrong. Next slide, please. So the virus is a respiratory tract virus. It is usually propelled out when we cough or we sneeze. It settles fairly quickly, which means it's more of a droplet virus than an aerosol virus. If we're unlucky enough to inhale someone's cough, that can lead to infection. If they cough on their hand and touch a door handle, and we touch the door handle and then scratch our nose a few minutes later, that can lead to infection. Inside us, it is generally not a good virus to have. Next slide, please. Now, the question, I mentioned door handles. There is a study that came out that looked for viral genetic sequences, and this is what's causing some of the angst out there. If you look for viral genetic sequences, the virus may hang around, and these are the red boxes, up to a few days on steel, on metal, on wood, on plastic. It can hang around. On latex, it hangs around for a little bit. Now, that is viral genetic sequences. The virus can't multiply outside the body, and whether this is truly infectious virus or not is questionable at the moment, but it's worrying that this virus can hang around in the environment. And it certainly tells me that I should watch door handles carefully, because I don't want some wet, moist sputum on a handle on a hand that's put on a door handle that I then touch and then accidentally touch my nose. Next slide, please. So what happens if we are unfortunate enough to run into SARS-CoV-2 virus? We believe that probably up to 25% do not even have any symptoms. That figure is soft. We haven't got good science behind it. We've got a lot of peripheral science that suggests it's probably in that range. And we worry about asymptomatic infections because these are people who may be infectious to others while not unwell themselves. If you run into this virus, it's believed that you likely will develop illness within 2 to 14 days, with a median of about 4 days. There is some nice science saying that 98% of people within 11 days will have developed symptoms if they're going to. So this isn't a virus where 2 weeks after you exposed, you get a little bit of a scratch, sore throat, you think, well, I wonder if it's it. Most of it is immediate within 2 to 5 days. The good news is that the current evidence is that 80% of those who are symptomatic and diagnosed have a relatively self-limited illness. They do not need hospitalization. They generally cure themselves within 14 days. So 25% may be asymptomatic. Of those who are symptomatic, 80% just smolder it along at home and get better. But 20% have severe illness and require some medical care and hospitalization. Some of the people who are in hospital have a disastrous respiratory course where they have what's called a cytokine storm that leads to respiratory failure, multi-organ failure, and requires intensive care. Now, the rate of the progression down the pathway of these isn't quite known, but generally we think within 10, 14 days, we'll know if someone's going to end up in dire trouble. Next slide, please. The problem with diagnosis, we have a lab test, but the symptoms are almost indistinguishable from flu. Patients usually complain of fever, dry cough, extreme myalgia, shortness of breath, very similar to what we call influenza-like illness. One little anecdote that's come out in the recent past is many patients actually complain that they can't smell or can't taste. And some of my colleagues who've been unfortunate to be infected with this said they noticed their coffee did not taste in the morning. So as long as your coffee tastes good, that is good in the morning for all of us. Next slide, please. Now, I mentioned that some people have a catastrophic course, and this is the breakdown of age. Now, as you can see, we believe from China, the average fatality rate is about 2 to 3%, probably about 2. But if you have an older population, a virus that would be relatively harmless in a younger population can have catastrophic consequences. And in the fatality rate in the over 80s, it can be 15%. That means that the risk to our society for fatality is mainly going to be focused on older populations. That doesn't mean that occasional younger individuals may not have a terrible outcome, but most of the severe illness will be in older populations. Next slide, please. So what do we have as treatment? Well, the best we have isn't bad, supportive medical care. Watch for superinfections from bacteria, maintain oxygenation, watch kidney function, watch liver function, keep people hydrated. It is all good, but it's not as good as we would like. There are a multitude of drugs being tested of proposed value, some of which have got very little scientific background to them, but someone thinks that they might be of value. Some are long shots and some are premature, but all of this is being driven out of necessity because as of today, we don't have a good proven drug. Now, this necessity means we've got about 500 trials going on globally, worldwide, And fortunately, we have several in Calgary. Next slide, please. Locally, as you've heard, Calgary Health Trust is helping both the CATCO study and the HOPE study. There is discussion about a post-exposure prophylaxis study for healthcare workers. There are some studies looking at the severely ill in the intensive care unit using anti-inflammatory agents and even passive immunotherapy. And those are for really the sickest of the sick patients in intensive care. So nothing is proven value yet. And I think the CATCO study offers the most scientific promise because it's 4 drugs and it's global, so the answer should come out fairly quickly. But certainly the HOPES trial has got some value as well. Next slide, please. So what else is in the news? Well, men seem to be more vulnerable than women, and we think there might be an explanation that men have got only 1 X chromosome and women have got 2. Blood type may be of interest, but it's not going to be blood type determines prognosis. It will be a secondary marker. There's noise about whether NSAIDs should be contraindicated, and most people believe, no, we should use them if we want. Pregnancy, well, we don't believe it poses increased risk to the fetus, but certainly having respiratory failure in pregnancy is very severely worrying. There is a lot of science now going on to prove the concern about is viral genetic material the same as infectious virus, and if not, what level should we worry about? There is data out of Korea where people are worried that people get recurrent disease, and that's triggered partly by people who are healthy having another swab that shows viral genetic material there. Are they really infectious? Are they not? Is it recurrent disease? Is it reinfection? And then there's the antibody test I was mentioning. If you have antibodies, does it mean you're immune to reinfection? Having antibodies is usually good, but it doesn't necessarily mean you're completely protected. That is scientific noise. Now, my last couple of slides, this is the way how COVID spreads. Along the bottom on the right is how infectious a virus is. And you can see that measles is extraordinarily infectious. Chickenpox, really infectious, polio, and then the pig box is the SARS-CoV-2 virus. If you look upwards, it is how serious that is on fatality. And you can see having Ebola is really serious. It's infectious, about the same as SARS-CoV-2, but it's far more fatal. And it gives you a perspective of where we are on the severity of disease and the transmissibility of the virus. Next slide, please. So in summary, SARS-CoV-2 is a new respiratory virus. It seems to be fairly easily transmitted in our current society, the way we're structured. It is difficult to diagnose clinically. It can be diagnosed by current molecular tests. At the moment, there's no vaccine, there's no serology, and we have no proven treatment, although we're working hard on that. Another point, most patients will do well and have no major medical issues requiring our hospital services, but in some, and particularly the old, it can be very serious and fatal. We hear a lot about flattening the curve, and that is because if we have multiple people all turning up at the same time very ill, it is very difficult to manage them. If we can flatten the curve that they present at a longer time span, it allows us to handle their medical needs more easily. And my last comment is, in this disease, we haven't got treatment, we haven't got a cure, so please leverage the prevention as hard as we can in society. And with that, I'll close and pass you over to my colleague, Dr. Viner.
Thank you, Dr. Gill, for that excellent clinical overview. What I'm going to do is discuss how Alberta Health Services and the larger health system has prepared and responded to the pandemic, how COVID-19 has impacted Canada, Alberta, and Calgary specifically. In terms of the AHS and health system response, I will highlight key objectives and actions that have occurred. An immediate key objective, as everyone is no doubt aware, has been to prevent spread to the public. Aggressive and early public health action has occurred at an individual and societal level, including initiation of physical distancing, public education about the importance of hand hygiene, staying home and self-isolating if sick, identifying higher risk individuals, testing them, and completing thorough contact tracing and follow-up of contacts, and putting strict measures in place to limit people congregating or working where they will be in close contact with one another. There's been particular attention on ensuring vulnerable populations are protected as best possible. HS has worked closely with the operators of long-term care facilities, the health directors of the Indigenous nations in the zone, shelters and corrections to assist with implementation of public health policies and procedures, access to testing, and to ensure that staff have PPE or personal protective equipment. We've also helped in the setup of an assisted self-isolation facility in Calgary for people who require isolation but are homeless. Next slide. We've taken measures, just go back one. We've taken measures to protect our health workforce from acquiring infection, including having screening protocols for all staff entering our facilities, all patients and visitors entering our facilities, and ensuring staff know how to use personal protective equipment properly and that we have adequate supplies available. HS is also currently conducting a pilot project where we are testing all patients admitted to 3 of our acute care hospitals, including asymptomatic patients, to determine to what extent patients may have COVID infection without manifesting symptoms. And the hospital where that's occurring in Calgary is the PLC. As I will elaborate on further in the presentation, we have taken steps to ensure we have the additional beds and capacity in our hospitals. We have also rapidly scaled up the ability of physicians and other clinicians to deliver virtual care by telephone or video link. We've partnered with family physicians and primary care networks so that patients can receive care in community clinics, avoiding having to come to emergency or the hospital. We have fairly stringent visitor guidelines in place to prevent visitors from spreading infection to patients or staff. And just this week, we're implementing a policy which requires all healthcare providers to wear masks continuously if they are providing direct patient care or unable to maintain physical distancing from coworkers. In addition to increasing physical capacity, we're also taking measures to ensure we have the workforce, equipment, drug supplies, and everything else we will need to meet future demands for care. In addition to the population, patient, and infrastructure-focused objectives, we have leveraged provincial data systems to inform decision-making. HS has struck a scientific advisory group, which does rapid literature reviews and synthesizes data to ensure best evidence is informing policy and practice. We've been collaborating with Alberta Health and other key partners, recognizing the importance of having a coordinated pan-provincial health system response. The next slides provide a picture of how the pandemic is impacting Canada, Alberta, and Calgary. So from an international perspective or global perspective, Canada has had a relatively modest number of confirmed cases of COVID. As most people would know from the media, although the pandemic started in China, the epicenter moved to Western Europe and is now in the US. It is important to recognize the prevalence of cases, those reported, is heavily influenced by the amount of testing that occurs, which in turn impacts on case identification and control. As you can see from this graph, South Korea had rapidly increased the number of patients, but through very aggressive testing and control, was able to flatten the curve within a short period of time. It's still early days for Canada and Alberta, but we're doing relatively well to date. From a national perspective, Quebec, then Ontario, have the greatest number of cases and deaths, with Alberta and BC having similar and the third highest number of cases. As of yesterday, and this data is updated daily on the Alberta Health website, Alberta had 1,870 cases, with 2/3 of those cases in the Calgary zone. We've had a lower rate of hospitalization than what was seen in China and many other countries, with only about 6% requiring hospitalization, and that could be because we've tested that many more people. But about 1/3 of those patients have required ICU care. Unfortunately, we've had 48 deaths in Alberta, which is 2.5% of all cases, which would be comparable to what many other countries have seen. Amongst many things, we've done a particularly good job with testing, as this graphic shows. Alberta has the highest rate of testing per capita in Canada and a higher rate than almost every other country in the world. Again, this is key to case identification, contact tracing, and control. The wealth of provincial level data has allowed for modeling scenarios to project the future number of patients that will develop infection. The models have been used to develop 3 potential scenarios. The most probable scenario is a limited spread scenario, where for every case, 1 to 2 more people are infected. There's an elevated spread scenario, which is what likely occurred early on in Hubei, China. While we are well prepared for this scenario, we think it is less likely. And then there's an extreme scenario, which reflects essentially uncontrolled spread and is exceedingly unlikely to occur in Alberta. The 3 curves here demonstrate the 3 potential scenarios. The probable curve reflects the flattening of the curve that we expect will be achieved through the good public health measures that have been instituted. I will note the timelines reflected on the x-axis there have shifted with that probable peak for the curve shifting into late May. The modeling work is dynamic and it's refined as we have more data on numbers of infections and the outcome of patients with those infections. This is the most recent data showing that in the probable scenario, we expect to have around 800 patients requiring hospitalization and 230 of these patients requiring ICU care. The peak in hospitalization, time is on the x-axis there, is now predicted to occur late in May. With the elevated scenario, the number of patients requiring hospitalization would be higher up, around 1,600, with around 400 of those requiring critical care. The peak in this scenario would occur more towards the beginning of May. Having reviewed the modeling, I will briefly review the capacity planning and response. So even now, as of today, HS has the hospital and ICU capacity required to meet the anticipated demand of the probable or elevated scenario. This capacity has been achieved by postponing elective and non-urgent surgery and procedures, transferring patients to community settings whenever possible, and utilizing all of our available space. ICU capacity will be increased as needed by adding beds to existing ICU rooms and using other areas that have proper equipment to provide care for ventilated patients. Multiple strategies are being employed to increase the available workforce. The learning institutions have been incredibly helpful in helping HS meet staffing needs, as have recently retired physicians and staff who have volunteered to re-enter the workforce. Having adequate supplies of personal protective equipment is of paramount importance to protect our workforce and has challenged healthcare systems around the world. HS has incredible strength in procurement, given the size of the organization and the experience and talent of leadership responsible for this area. We're quite confident that by leveraging existing supply chains and, if necessary, utilizing promising methods to decontaminate and reuse N95 masks, PPE supplies will be entirely adequate. What has been truly remarkable is how HS, as a provincial integrated health system, has been able to mount what we expect will be a highly effective pandemic response. Every area, from environmental services to supplies procurement, information technology, facilities management, workplace health and safety, human resources, and multiple clinical areas, among others, have rallied together to best ensure the health of patients and members of the public is protected and maintained to the greatest extent possible. The critical role of Alberta Health and community partners cannot be overstated. The support of the Calgary Health Trust has also been of incredible value. The challenge we're facing over the weeks and months to come has truly brought out the best in many, many people. And I would say for that, all of us should be very proud. I will end there, and we're happy to take any questions.
Great, thank you so much, Dr. Viner and Dr. Gill, for just a really amazing presentation. We had a lot of questions come in. Maybe I'll try to get to as many as I can in about the 10 minutes we have, but maybe I'll just start with a question about, Dr. Viner, your presentation showed high numbers in Calgary specifically. Is there any indication in terms of why Calgary's numbers are so high and how that's being looked at?
Yeah, we think the most likely reason is having more people who actually travel, having the international airport, and knowing that early on the primary mode of transmission was through people who had traveled, and that has now morphed into having more community spread, person to person spread within the communities, but certainly travel is probably the reason.
Great. The next question is maybe for Dr. Gill. There's been a lot of discussion about COVID-19 staying on surfaces for up to 3 days. So a lot of people are, the example used was a lot of people are wiping down their groceries from top to bottom using Lysol. Can you, I know you covered this a little bit on your table, but can you maybe mention if this is important, what steps people should be taking for surfaces?
That's a common question. Certainly the media show people bleaching the outside of their milk containers and washing their vegetables. I can tell you, first of all, remember this is a virus. The moment it leaves the body, the numbers decrease because it can't multiply outside the human body. It depends on whether the virus is exposed to UV light, humidity, whether it comes out, it's protected by some other liquid, whether it's in an aerosol or whether it's in a mist that allows it to survive longer. Now, with regard to surfaces, generally we can find, as I mentioned, viral genetic material 3 days on a hard surface, but most people believe that is not live virus, and one hopes one doesn't scrape a milk container and then immediately scratch your nose, because that probably wouldn't be wise, but it probably is not the risk. What I personally do is I wash my hands when I come home, I unpack all the groceries, and then I wash my hands again. And I think that is practical. I know some of my colleagues do Lysol a few things off, but it depends what really the risk is. And the virus continuously die, the numbers die as soon as it leaves the host.
Great. The next question, actually over to you again, Dr. Gill, is you identified the aged older people as a high-risk population, but can you talk a little bit about those with COPD or asthma and what effects they have or precautions they should be taking?
Well, they are no more susceptible to get infected, but when they do infect, if you've got a compromised respiratory tract, the outcome will be worse because they don't have the capacity, the redundancy to have part of the respiratory tract infected and not providing oxygenation. So extra precaution not to be infected, and then when they do become infected, they need to be watched with more caution because they don't have the capacity to deal with the infection easily.
Great, and one more for you too. Somebody asked this question a little bit earlier, but what is the truth behind ibuprofen worsening the symptoms? Can you address that?
Yes, the French Minister of Health announced it at a French press conference, and everyone said, wow, that's interesting. And we've been waiting for the science to come out. And to date, I've not seen anything to support it. There are some theoretical considerations that, all else being equal, you might want to take acetaminophen rather than ibuprofen, but there's no science out there. And unfortunately, it comes back to political meddling in basic science communication.
Great. This question might be for both of you, but are you able to talk a little bit about the process to confirm the presence of COVID-19? I know, Dr. Gill, you covered some of the testing protocols, but just in terms of how long it's taking to secure results and the goal to achieve the number of tests per day in looking at potentially how many people could be affected.
Yeah, I can speak to that, and then Dr. Gill can add comments. So, when we first started ramping up, if you will, to respond to the pandemic, we were able to do around 300 COVID tests per day. We've actually got the capacity to do around 7,200 tests per day, and by the end of the month, expect to be able to do hopefully as many as 20,000 tests a day. Most of the testing is being done in assessment centers, and most of those have people driving through to minimize the contact with other people, including the healthcare workers that are doing the swabbing. So we right now have 4 assessment centers, one in each quadrant of the city. Early next week, we're going to open a 5th center up, which is out near Callaway Park there, kind of on the west side of the city. And just as an example, the assessment centers yesterday did in the neighborhood of 2,000 tests. So, as people may know from the media, the actual criteria that would enable people to get tested have been liberalized, if you will. So basically anybody with fever, cough, shortness of breath, sore throat, runny nose can now get tested. And, part of the reason those criteria have been liberalized is A, we have the testing capacity, and B, it'll give us better data on the number of people that do have COVID infection out in the community.
Great. Dr. Gill, is there anything you'd like to add?
No, I completely agree with Dr. Viner. The more testing we get done, and then the introduction of serology when we have a good validated test will give us a much better picture on how well we're doing, where we need to go. So testing is very helpful for control of this pandemic.
Great. I have lots of questions are coming in, so I'm going to try to prioritize these the best that I can. But can you maybe talk a little bit about what happens when summer comes, and we're back to fall? There's a lot of discussion around wave 2. If we've not yet been in a position to find a vaccine or a treatment, what does that mean?
Well, I'll give it the intro and I'll let Dr. Viner complete. With summer, people tend to be socially distanced because they tend to be out rather than inside in group family settings, which might be advantageous. There is probably the virus, if you cough out in a UV environment, such as in sunshine, it probably is inactivated fairly quickly. And there's good information on influenza, how the virus in UV light is destroyed very quickly. But what will happen is the big concern about the second and the third waves that are in the media. And maybe Dr. Viner would like to comment on his thoughts on that.
Yeah, I think the truth is we don't know right now when wave 1 is going to end, and certainly the peak projections when most, when we're going to see the most people with infections requiring care, the projected time of that peak has moved a month later than what we thought a month ago. And, you know, as I said earlier, the modeling is very dynamic. As we get more data, we refine the model, or the model, you know, the projections change because it's local data. You know, it's based on actual attack rates in Alberta. So it's pretty hard to know at this point when wave one is actually going to peter out. We think it'll likely be over the summer, and unclear when wave two might then begin. The other thing is, for the last question, I forgot to comment on the turnaround time. So the turnaround times are in the neighborhood of 1 or 2 days now on the testing. Sorry to jump back and forth.
That's good. So the next question is kind of thinking about the future. There's two parts to this question. The first is what is AHS's plan for this COVID or post-COVID world, and how will safety be top of mind for both employees and people when businesses start up again? And kind of what is the view on the second part of the question, which is very similar, is I guess what's the anticipated plan for normalcy in Calgary regarding businesses and how people can return back to work? Are you able to comment on that at all?
Yeah, it's Dr. Gill may be able to comment. It's a little hard for me to comment on what the restarting of business and whatnot may look like and when that's going to occur. That'll be largely determined by the Chief Medical Officer of Health, Dr. Hinshaw, who provides an afternoon update most days of the week. In terms of protecting people's health and safety, what will happen is more and more people in the community will have had infection. Some of those will be asymptomatic. Up to a quarter of them, as Dr. Gill had pointed out, will have asymptomatic infection. A good number will have mildly symptomatic infection. And as that occurs, the population will have what's called herd immunity, where there's enough people that are now immune to COVID-19 that the risk of people who may be lacking immunity of encountering infection decreases. And based on knowing how many people have tested positive, and then once it's available, antibody testing, I think again people will be able to do modeling that will provide risk assessment, which will inform when people can start resuming normal social and business activities. In terms of HS returning to normal operations, it'll have to be at that point where the risk to patients, public, and healthcare workers is low enough that a lot of the current needs for social distancing and whatnot, visitor restrictions, no longer apply. And I think we have to get through most of the first wave before we can look at how we're going to address the pent-up demand that we know is growing day to day as elective surgeries and whatnot aren't being done.
Great, thank you, Dr. Viner. I'm gonna ask 4 more questions just in respect of time, but I know that a lot of people have a lot of questions, so we'll figure out a strategy to make sure that Dr. Viner and Dr. Gill get your questions, and we can maybe respond in a little bit of a Q&A format when we send out the recording of this. The next question is about support for long-term care facilities. I know that there's been a lot of news and a lot of unfortunate spread happening in long-term care facilities. Can you talk about what measures AHS is implementing to assist seniors' homes?
So we're really focusing on the long-term care facilities. We know that half the deaths, unfortunately have occurred in long-term care. And, we've done a few things. One, to reach out to all the facilities and ensure that if there are any staff educational needs, around infection and prevention control practices, how to use personal protective equipment properly, anything at all that we respond to those needs. We're requiring the medical officer of health has actually required that any long-term care center that has even one patient with what's called influenza-like illness. So that's the symptoms. It could be COVID-19 symptoms, or it could be another respiratory virus, or something else altogether. But if they have even one patient, they have to notify the medical officer of health, and Alberta Health Services with the MOH then has a rapid response team that goes to the facility, kind of reviews everything that is important to ensure that a rapid diagnosis for a symptomatic patient or patients, any healthcare workers occurs, that very rigorous contact tracing occurs, and that requirements for infection prevention and control are in place and rigorously adhered to. We've actually got a 1844 number that they're supposed to call if they have questions or any symptomatic patients, as I mentioned.
Great. This one's for Dr. Gill. Dr. Gill, there's a lot of differences in how people are classifying death by COVID. The comment here is that it seems like some countries are not counting people who might die from things like heart attacks but are positive for COVID-19. Other countries are counting that. Are there comparative based on similar apples to apples?
This is a big problem that became more widely acknowledged in the UK, where they have their COVID deaths, and then they looked at deaths in the community, particularly in care facilities, and they found whereas the average for many years was about 10,000 deaths a month, that during COVID there was 16,000. And their suspicion, that does to me not seem unreasonable, was that there were 6,000 extra deaths that might well be strongly related to COVID, but were just classified as someone didn't breathe very well, their heart failure got them, their heart attack got them. So comparing apples to apples is really important, and I'm all for the best, honest, open information out there so we know what we're doing, not by accident or by plan misclassifying things. So it's an very interesting question.
Great. And I know, Dr. Viner, you mentioned that Peter Lougheed Center is one of the zones in Calgary that is testing for asymptomatic. Are you able to comment on how many of the asymptomatic tests there have been positive? And
Well,
also,
as of yesterday, none, interestingly enough.
oh, great.
So the pilot hadn't been in place for even a week yet. As I recall, it would have been roughly 4 or 5 days, but at that point, none.
Are you able to comment as well about the infrastructure that is being built just outside the PLC, the big Sprung building that is being built to support Peter Lougheed Center, and how that will be used?
Thank you. Thank you for the question, actually. So through a very generous donation from the Sprung family, we're putting up a portable structure, and amazingly enough, from beginning to end, it'll be in place by the end of next week. It's taken about 2 weeks. It will have 67 beds within it, complete with what's called a head wall. So it's the head wall, from the head wall that we get oxygen, suction, electrical, everything that we would need to look after a patient. It'll initially be used to decant the emergency department. The PLC Emerge is busy at the best of times and fairly congested. So an immediate use will be to decant the Emerge to allow for physical distancing. Patients with suspect COVID will be preferentially sent over to the portable structure. And if the need arose, we could look after up to 67 patients in that structure, and time will tell whether that will be necessary or not.
Amazing. I guess just one more question for you, Dr. Viner. Can you just comment if you've noticed or how you've noticed having a provincial integrated health system has benefited COVID response compared to other systems, both in the country and around the world, that maybe don't have that integrated model?
Yeah, I think what it's allowed us to do is really leverage the knowledge, the expertise of many very experienced, highly skilled individuals to achieve common purpose in a way that you could never do otherwise. So, we have people who are co-appointed at the universities and within Alberta Health Services. They do research, they do clinical work, and those are some of the people that are leading these clinical trials. We have, as I mentioned earlier, supply chains that, just because of the size of Alberta Health Services, have really given us a lot of clout, if you will, with some of the suppliers in China and other countries. One of the choke points to getting supplies out of China has actually been transportation. So HS chartered a cargo plane to go pick the supplies up, but was able to get amounts of supplies that I think other individual regions, certainly individual hospitals, would never have access to. Another example would be the scientific advisory group. We've got a lot of questions that come up around what's the best way to do something, and by working at a provincial scale, we have experts that come together and look at emerging science. As Dr. Gill alluded to, there's a lot out there. It's important to sort out what is potentially valid, accurate, and something we should be actioning versus what's too early and maybe misleading. So we've got a group that works provincially on that, and then just developing common communications, provincial support for long-term care centers across the province. Again, I think if we were doing this on a smaller scale, the rapidity with which we could get things in place and the quality of what we'd be getting in place just wouldn't be at the same level. And then there's provincial level data. We're collecting data, in many instances on the entire population, and that is hugely powerful in terms of informing decision making.
That's great. I'm going to leave the questions there, though I know many people probably had some questions about masks, and Dr. Gill was kind enough to also answer a little bit offline, and just to say that doesn't use them for care outside of patients, but he washes his hands a lot and does not touch his face. So if you had questions about masks, that's a summary. I'm going to turn it over to Mike, just in respect of everybody's time. But like I said, we will try to answer as many questions we didn't get to.
Great, thank you, Valerie. As we wrap up this presentation, just wanted to thank each of you for joining us today and asking such important questions. I'd also like to thank Dr. John Gill and Dr. Sid Viner, without whom this engaging presentation would not be possible. Earlier, Dr. Gill talked just about the staggering amount of information and the challenge it is sometimes to assess the quality of that information. And I have every confidence that we've been the recipients of some great quality information today. So thank you to both of you for joining us. As I mentioned before, we've recorded today's session and we'll share it through email so that you can listen to it again or share it with others. Calgary Health Trust does exist to better the health and families and individuals, the health of families and individuals in our community. And our mandate is now as clear as ever. COVID-19 reminds us that as a community, our healthcare needs can sometimes be unexpected and are constantly changing. And we're proud of the work that we do alongside Alberta Health Services. And it's through support like yours as donors that we can better navigate the changes that COVID-19 will bring. Thank you so much for attending and for being part of our philanthropic community. Thank you and have a great day.